Good morning, everyone. My name is Arnaud Muller from WHO. Thank you for joining. We are still waiting few colleagues to join. They have some technical issues to join the meeting. Apologize for the slight delay. We'll come back to you in a few minutes.
Good morning, colleagues. Thank you so much for your participation. So without further delay, we can start this meeting. Can you hear me? I think you can.
Yeah, we can hear you.
Yes. Thank you so much. So again, good morning, colleagues. So we all know that you have a very busy schedule, and we thank you again for your availability. This meeting was organized in the view of the importance that WHO and the regional office place on improving access to quality antimicrobials and antibiotics. Antimicrobial resistance is one of the flagship programs in the region, which is supported by member states for several reasons with regard to the impact for public health. On behalf of Laetitia Gahimbare and the AMR team in AFRO, I would like to welcome you in this meeting, and I wish you also a fruitful meeting. During this webinar, we'll have several sessions, and we'll have panel of speakers. Here you can see the agenda. We will start by these glass consultations and we'll give you an overview of the context. And we'll go in deep with the methodology and the different experience that we have in the region. Thank you so much to all of you. And I am opening this meeting by giving now the floor to Arnaud Muller. Thank you so much. Over to you, Arnaud.
Thank you. Aissatou. We will start this meeting by an introduction to the glass consultation. Let me share the screen, the correct presentations now. Do you see the screen?
Yes.
Okay. Okay, I will briefly introduce you to the glass technical discussion on surveillance of antimicrobial resistance and use that is ongoing and that this webinar is part of. The global system for surveillance of antimicrobial resistance and use was launched in 2015 by WHO, initially focusing on antimicrobial resistance surveillance, but expanding to other aspects over the years, with now other modules or components included, such as the emerging antimicrobial resistance component to report new emerging resistance, or the antimicrobial consumption module to report antimicrobial consumption. And so we are working on new modules, for instance, reporting on resistance in candida species, or for reporting point-per-on-server antibiotic use in hospitals, or the tricycle E. coli, ESBL E. coli project from the WHO. And finally, also we are working about having IT tools for reporting burden of disease on AMR. Over the last 4 or 5 years, we, of course, supported countries to carry out establish a surveillance system in their countries. And we also started by enrolling countries from 2016. And as of October 2020, we have almost 100 countries on glass. And this 4 or 5 years of existence of the project was very important for us, because we learned, we had a lot of feedback from countries, and we are now in the time and the period to review these 4 or 5 years and to discuss what could be the next phase of glass. And that's what we are doing, this glass technical discussion. We want to discuss with you what we have done, the new tools we are developing, and how glass should look for the next years. There will be an online technical discussion with member states, other stakeholders to discuss glass. The consultation of the technical discussion started in October and will end in February next year. And we will have also finish this technical online consultation by a physical meeting with selected member states in Stockholm in April next year. To go to the online technical discussion activities, this will go through regional webinars, and we have 4 thematic areas we want to discuss with you. And part of this work is to review 5 glass documents, and we will ask member states to provide feedback to WHO on these 5 documents. There has been a website set up for that. There will be online discussion fora if you have any questions about glass on the 4 thematic areas, or with the work done in the regional in the regions. And we hope that this will be important point with lots of discussion between member states, stakeholders, and WHO. at regional level or global level. As I said, we have 4 thematic areas to be discussed during this online technical discussion. The first one is the antimicrobial use surveillance methods, and we're more focusing on national hospital antimicrobial consumption surveillance, and that's also the topic of this webinar. There will be also an area on microbiology laboratory. They will also have one on AMR surveillance methods. And finally, the last one is on One Health surveillance models. In terms of documents, we will ask countries to provide feedback on 5 documents. There will be the AMR surveillance manual. There will be the early implementation protocol for the inclusion of candidate species. And also about the method for estimating attributable mortality of AMR bloodstream infections. Another document about the whole genome sequencing. And finally, important for us today is the GLASS guide for monitoring antimicrobial consumption at hospital level. All this, you can find it on the WHO website. Just is to show what the online feedback forms that you will have to fill in to report your feedback to the WHO. Timeline for our activities or our thematic area on antimicrobial use surveillance methods. We have the 2 African webinars today. One this morning and one this afternoon, and we will open the window for feedback on the GLASS guide for monitoring antimicrobial consumption at hospital level from the 15th November to the 15th January. Then please use this period to report the feedback to the WHO on this document. And that's the GLASS 2020 platform where you can access to get more information about the online consultations, where you will have information about the different webinars, where you will have also the forum for discussions, and you will accept the forms for feedback. With that introduction on the GLASS consultation, we'll move to the first presentations, the next presentations, which will be about why we want to measure antimicrobial use. Do you see my screen?
Yes.
Okay. Then why we want to measure the use of antimicrobials? This is important to know that more we use antibiotics, more we lose them. It's just a natural process. And it has been shown that the use of antimicrobials is one of the main drivers for development and spread of AMR, as you can see on the left, and both human and animal use, misuse or overuse, are driving AMR. And you can see on the right that there is a nice correlation between the total consumption of antibiotic in one country with the rates of resistance in the same countries. And that's for penicillin resistant streptococcus pneumonia. When we look at the consumption, we can see that over the last 20 years, we have seen an increase of consumptions by 65% more recently. And what is worrisome is that we can see that the most increase is happening in low and middle income countries compared to high income countries. And the response from WHO and other global agencies like OIE and AFROW was to develop a global action plan to fight AMR. which was endorsed by member states in 2015. And among the Global Action Plan on AMR, there are two objectives related to surveillance of resistance and use of antimicrobials. The first one is Objective 2, which is about strengthening the knowledge and evidence base through surveillance research. And the second objective is the optimization of the use of antimicrobial medicines. The aim of the Global Action Plan is to ensure continuity of successful treatment and prevention of infectious disease with effective, safe, quality assured medicines that are used in a responsible way and accessible to all who need them. And this surveillance data will inform any policies, actions to improve or to get this goal achieved. And another important part of the Global Action Plan is that there will be a call for all countries to collect and report data on antimicrobial use, in addition to our antimicrobial resistance. And what also has been acknowledged is that the limited surveillance activities and very limited data generated by low middle income countries on the use of antimicrobials and also on resistance. And as part of the Objective 2 of the Global Plan, we should develop a global system for surveillance of antimicrobial resistance and use. The glass, and you can see that there is at least here on this slides two components shown: the surveillance of antimicrobial resistance and then the surveillance of antimicrobial consumption. When we look at Objective 4, WHO has an integrated approach for optimal use of antimicrobials. And then you can see that if you think about optimizing the use of antimicrobials, you need to think about antimicrobial stewardship programs, national level, but also hospital level. We have all the aspects of the essential medicine list and also the aware categories. And in terms of domains, we have to think about regulations, policies, rational use, clinical guidelines, and also importantly, the pricing and availability. And all this can be informed when we have data. Then it's important that data we collect on the use is fulfilling the needs of all these domains of activity in the Objective 4 of the GAP. Basically, with this, what we aim is to reduce antimicrobial resistance and to increase the access to medicines or antimicrobials, if we look at the scope of this project. And as I mentioned, if you want to improve something, you should know about this thing. And if you cannot measure it, you cannot improve it. Then data are very important to identify issues and to propose solutions, and then to measure the effect of the interventions. And you can see it's a never-ending story. It's a cycle that you repeat until you get the goal you want to achieve. And when we look at data on antimicrobial use, why we want to measure and what they can tell us. First, they can tell us, let us know to the patterns of use of antimicrobials, which mean patterns, type of antimicrobials, but also quantities used. We can also have information about prescribing practices and appropriateness of use. And with that, we can, of course, it's very important to compare across local, national, international levels. When we have data over time, then we can also look at trends. And finally, we can do benchmarking. How we can use this data? As I said, if we measure, we can identify and provide early warning of problems with antimicrobial exposure and use. And from that, we can develop interventions to address these problems. Then we can monitor the outcomes of interventions. We can have information about prescribing quality when we look at adherence to practice guidelines, We can also raise awareness among healthcare workers, consumers, policymakers about the situations and the problems, if there are problems, and how this could contribute to development of IMA. And that's also the last point is, of course, we want to be able to link the use to the development of IMA. When we look at the use of data on antimicrobial consumption at national level, some other example is we can understand the market of antimicrobial medicines. We can inform and follow up regulations related to antimicrobial medicines, and of course we can with that also improve the use of antimicrobials through rational use interventions. As I already mentioned, we can link with IMR data, and what can also be done is we can also link consumption in humans and animals, which is important when you do regulations on one sector, how that could impact the other sector. Other examples, for example, when we discuss with regulatory staff, what about the market of medicine? For example, when you do consumptions, are all antimicrobials you consume registered or not in the country? Then in this case, we can see, for example, if there is failure in importation controls, parallel import, all these things. So are the antibiotic consumed reflect the epidemiology of the diseases? All these things can be done with consumption. Yeah, still some points about the regulatory market, which is an important target for consumption data. And we help driving better regulations and rational use actions. Just a concrete example, when we look at number of products per substances from the data we got from our reports we made in 2018, you can see, for example, Sudan reported almost 400 different products for amoxicillin inhibitor. Côte d'Ivoire, 100 products for amoxicillin enzyme inhibitor. Burkina Faso, 83 products just for the same substance. And then we have also a lot of use with ceftriaxone, cefuroxime, and then azithromycin. And then you can see that do we really need this 400, knowing that more products has been shown that more products you have, more competitions you have, and more use you have at the end. When we change the audience, you can see that the questions and the answers will be a bit different. Is it in line with the most frequent infections and part of the recommended antibiotics for these infections? Then you can link that with more clinical aspect of stewardship programs. This is just examples now to show you that, for example, on the left, it is data from the WHO report from 2018. On the left, you have data for some countries expressed by class of antimicrobials. And then you can see high variability between countries. On the right, you have the consumption expressed by aware categories. Then you can see in blue, dark blue, the access group. And then in brown, the watch, the almost very little in terms of reserve, the blue line, and then the other that were not classified from the first categorization. That's ways to show the proportion of access group per country, which is one of the WHO indicators for rational use of antimicrobials. You can also use that for monitoring interventions, and that's just examples from 2 countries in Latin America, where they look at the consumption before and after interventions. And in both cases, what you can see that there could have been impact or no impact, and that was on over-the-counter interventions in these 2 countries. Another way to look is to look at resistance and consumption in one country. This is the Czech Republic, where you can see that you have the line is the resistance to erythromycin, and the bars are the consumption of macrolide. And you can see you have a delay. When you start decreasing the consumption, then the resistance will decrease, but a bit after. Another way to show this is also linking consumption of fluoroquinolones with resistance in E. coli. On the left, it's humans, and on the right, it's animals. You can see that there is also again a relationship between the level of consumption and the level of resistance per country. Every point is one country. Another way to look at resistance and consumption, but this case at hospital level. Here, what is important to see is that we can have a full linear relationship on the left, which is carbapenem use and Acinetobacter pneumoniae resistance to carbapenems. But when we look at use of aminic glucosides and resistance in Pseudomonas aeruginosa, you can see we have a non-linear, we have a threshold. That means you need to reach a certain level of use to see an impact on the resistance. And for that, what is also important to note is that we don't have one method that is able to fulfill all this. Then we have to develop different methodologies, and we have focus on two aspects that we call surveillance of antimicrobial consumption, which is estimates of aggregated data, mainly data coming from import, from sales, or from reimbursement. It's data that's not really the used by patients, but it's a proxy, and it's much more easy to collect. And with that, we can answer two types of questions: what is used and how much is used. And then we need also other type of tools to monitor the use of antimicrobials. In this case, the use is what we mean is patient level data. And with that, we have data by patients. We have information about the patients, about the diagnostics, about the medication order, dispense, lots of information, but that is much more difficult to collect. But with this data, we can answer questions by who is using it, how it is used, and when it is used. And just to summarize the different tools or reports we have, on the left, we have the methodology for the surveillance of consumption at national level. We will discuss just after this presentation. And we have also the report from 2018. We have a new document that we also talked during this webinar. It's a hospital guide, the guide for monitoring antimicrobial consumption at hospital level. We also developed, based on the feedback we had from countries, a manual for data management to help countries to manage the data, how to do basic data management task and analysis. And finally, the last on the right is the WHO protocol on surveys on antibiotic use in hospitals to get data on use at patient level in this case. That was for the introduction about why emerging antimicrobials. And now we will move to the African context with AISA2. AISA2, yeah.
Okay, thank you so much. I don't know how to really, okay. Okay, you can see my screen clearly?
Yes, we can.
That's great. Thank you so much. So good morning again, colleagues, and good morning to my fellow speakers. I'm pleased to speak with you about the monitoring of the consumption and use of antibiotics in the WHO African region. I thank my colleagues for the invitation to this important event. My name is Aissatou Sougou. I'm WHO Technical Officer for Essential Medicine and Medical Product. So here, the colossal work done by countries has resulted in all 47 countries in the African region having national medicine policies inclusive of antibiotics, and almost as many of them having national essential medicine lists as basis to prioritize investment. The African region has placed regulatory authorities at the center of the fight against antimicrobial resistance, in particular through its essential function of market authorization, market surveillance, and rational use. They have an impact on the monitoring of antibiotic consumption and rational use of those products. However, if all countries have a national drug regulatory authorities, many are not able to perform the essential function expected. It is even considered that more than 60% of African countries have minimal or no medical regulatory capacity. However, we must acknowledge the considerable efforts that have been made in recent years to improve the capacity of these authorities, to strengthen inspection at the level of dispensing points, and to structure the quality control of medicine through annual sampling plans at the level of public dispensing structures. In terms of availability of antibiotics, the reliable availability of affordable and high quality antibiotics remains a major challenge for the African region. Challenges related to consistent and reliable access to antibiotics go beyond physical availability or practical accessibility. Cultural and attitudinal barriers are also persistent. The graph above provide a snapshot of availability of antibiotics during a pilot study conducted across 19 capital cities. That is it doesn't account for the opportunity to order additional inventory, but rather immediate product availability for the patient. Amoxicillin 500 milligrams was found to be widely available across most settings, meaning 80% of facilities surveyed in the Afro region. The survey note low availability, less than 30% of the children amoxicillin 250 milligram dispersible tablet in most countries in the African region, except for Tanzania, Zambia, and Zimbabwe. Median availability of injectable penicillin was approximately 64% in the Afro. However, availability of penicillin, benzene penicillin may be affected by global supply chain shortage. That could be understood. We found that the variation in availability between countries was greater for amoxicillin than cotrimoxazole, which is often widely distributed within countries because of HIV programs. They have made substantial investment in supply chain management to ensure its availability for prophylaxis. However, the availability of cotrimoxazole can result in a larger prescription even if it's not appropriate. In Congo, DRC, and Cameroon, it is important in execution of the expensive amoxicillin clavulanic acid. Access and watch antibiotics showed good availability in the health facilities, even if it's lower than the 80% quota targeted by WHO. However, availability remains disparate in the region and can vary within a country, particularly in rural areas, with, for example, antibiotic availability of less than 57% in the Comoros in rural areas. A comparison of MIDAS-cell data for 10 French-speaking West African countries that you can see below in the graph shows that the total volume of cell was the lowest in the African region for pediatric antibiotics compared to the other region in the world. So, however, Sub-Saharan Africa reported high and possibly inappropriate percentage of antibiotic prescription in the range of 51 to 85% sometimes, and it's both applied to adult and pediatric prescription. They also showed a high use of antibiotics by people with malaria, despite the availability of rapid diagnostic tests for malaria. Here, in terms of quality of antibiotic, an estimated 1 in 10 medical circulating in low and middle income countries is either substandard or falsified. This means that people are taking medicines that fail to treat or prevent disease. Not only is this a waste of money for individuals and health system. Since 2013, WHO has received 1,500 reports of cases of substandard and falsified products. So far, the threat for criminals is to make the low prices falsified product acceptable to large number of consumers. They do this hijacking marks of quality because antibiotics and other antimicrobial medicine are manufactured and prescribed at doses designated to destroy the pathogen that are causing illness. Countries with a higher circulation of substandard and falsified products and porous medicine market are more likely than to develop an antimicrobial resistance, a drug resistance. Recently, an estimated 70,000 to 150,000 deaths caused by substandard and falsified antibiotics in children under 5 suffering from pneumonia was registered. But precapitulation processes are available for few antibiotics, notably for commonly used for treat opportunistic infection associated with HIV, but it's not yet enough. So, however, knowing the intersect linkages between substandard and falsified and antimicrobial resistance, many efforts are being made to limit the circulation of fake medicines, including antibiotics in the region. The UMOA, which is an economic group for West Africa, has recently worked with 8 countries on regulatory texts on market surveillance, strengthening the mandate of quality control laboratories and the import control of antibiotics. Similarly, some countries such as Senegal and Ethiopia are moving towards serialization, which allows the authenticity of antibiotics to be verified down to the last user through a Brooks traceability system. Moreover, the African region is still involved in the MSM member state mechanism, which reinforces cross-border collaboration between the national regulatory authorities in Africa and the rest of the world. Although these recent developments are highly commendable, but the prevailing SF pandemic seems that they are grossly inadequate for the attainment of the desired quality of healthcare delivery and for safeguarding of antibiotics. So, in terms of antimicrobial consumption in Africa, concerning the monitoring of antibiotic consumption, since the development of the AMC methodology, the regional office has been keen to strengthen the capacity of member states, of experts from the member state in order to enable them to the implementation of autonomous national program for monitoring antibiotic consumption. Since 2016, 41 countries have been capacitated with more than 200 experts with different profiles. These profiles were intended to facilitate coordination at national level in the context of One Health. However, it is noted that only 28%, less than 30% of the countries in the region have conducted an AMC survey on 2017 to 2019 data. And of this country, only Benin and Tanzania have been able to report on annual data while maintaining a stable AMC program. For the majority of the 13 countries that were able to report, only 50 reported over 2 successive years. Roughly speaking, the implementation of the AMC program remains weak in the African region, with more than 72% of capacity countries never having conducted a survey. But among the barriers identified are the turnover of certified experts who are no longer in the post, the difficulty in linking AMC data to the outcome of the national groups. The list is not exhaustive, and I hope it can be expanded during the discussions. A similar case applies to survey on the use of antibiotics in hospital. Although this is not the subject of a surveillance program, but a one-off survey, only 31% of the region were covered in the majority, thanks to the Fleming Fund and the support of DEFCO. In Cape Verde, however, the monitoring of use of antibiotic in the hospital environment has been in place for a long time. Thanks to the support of a HIA tool, it is moving towards a digitalization of the system, which was previously paper-based. In Cape Verde, the main advantage of this system is that it makes it possible to identify the disease for which antibiotics are most commonly used. And it has consistently shown that most antibiotics prescriptions are more respiratory diseases, for respiratory diseases. So, what about the oral classification? But how do we do that? And still ensure that patients are treated effectively in Africa? WHO has developed a tool to help regional and national decision making on which antibiotics to use when. The tool indexes the most effective antibiotics into 3 different groups: access, watch, reserve. By promoting responsible use of antibiotics, access antibiotics should make up at least 60% of national consumption. This will not only result in better use of antibiotics, but also in reduced costs and increased access. Reaching this threshold by 2023 will contribute to countries achieving health-related targets of the Sustainable Development Goals in Africa. Then by 2023, 60% of all antibiotics consumed must come from access, the group of antibiotics at lowest risk of resistance. So the overall goal is to reduce the use of watch group and reserve group antibiotics and to increase the use of access antibiotics where availability is low. So our work could translate into longer lifespan for the antibiotics that still work well today. Expanded access in developing countries and reduced resistance globally, in other words, in Africa specifically, better health for all. As part of the update of the WHO model list of essential medicine in 2017, WHO carried out a comprehensive review of antibiotics and introduced a new categorization that I described above to guide the prescription and treatment while monitoring consumption of the optimal antibiotics for many common infections syndrome in adults and children. In 2019, the classification was further reviewed and expanded to the most available antibiotics and to reflect experience collected between 2017 and 2019. By October 2020, WHO has supported the organization of virtual national meeting and regional meeting on the hour categorization in Africa. This year only, we organized more than 5 training, national and regional. The training are still ongoing, and there is one plan this November. I will share later the details, so you are all invited to attend this aware categorization training. To date, 10 countries in Africa has successfully updated their national essential medicine list to introduce the aware categorization, which is a true success in the region. So, just to show you how our country in Africa actually are connecting the work they are doing in our categorization and the work they are doing in antibiotic consumption. We have some very good examples of policy options adopted by country. So countries actually in Afro that are both updated the national essential medicine is introducing carried out an AMC. Countries adopt policies to use AWARE in the following 3 areas in order to optimize antibiotic use and strengthen stewardship actions, meaning stewardship program. First, AWARE is used for the monitoring of antibiotic consumption regularly. Measuring antibiotic use is a key component of antibiotic stewardship. So measuring antibiotic consumption by quantifying the use of antibiotics in each of the AWARE categories allows some inference about the overall quality of antibiotics use in a given country. Countries should first compare and benchmark their own national and regional antibiotic use using absolute consumption data. For example, an overuse, and I will just swap the example, so Anno can maybe give you more detail later on that. And actually, the global indicator for AMC is a proportion of antibiotics of 60%, so overuse. Secondly, also, the alignment between the national essential medicine list with the WHO model EML. It is one of the policy options. Many countries list in the national essential medicine list or in hospital therapeutic formularies antibiotics that are not part of the standard treatment guidelines, or too many antibiotics of the same class. Antibiotics on the AWARE list should be prioritized for procurement, access, and distribution to different levels of the healthcare system. This is actually one of these examples being carried out in Benin. So deviation from this should be justified. For example, by document difference in the epidemiology of pathology. This should help to make first-line antibiotics with low resistant potential available, while reducing the use of broader spectrum medicine. Lastly, AWARE help to update or establish national treatment guidelines for infectious syndrome. National treatment guidelines should reflect the AWARE categories by specifying the recommended clinical indication for each antibiotics and the AWARE category corresponding to each antibiotic. This will help to achieve full consistency between guidelines and appropriateness monitoring. And we have a very good example in Tanzania that because Tanzania has set a committee now to monitor the alignment of the standard treatment guidelines. They are working very hard on making a consistency between the national essential medicine list, the standard treatment guidelines, to implement the antimicrobial stewardship program. So fully informed by these guidelines. So watch group antibiotics should, for example, only be recommended for the syndrome. And for them, what they do is they are listed as first or second choice option. So they are making this alignment within their own also national essential medicine list and make it widely available. This is a Tanzanian example. So based on AWARE and instrument design using rigorous evidence-based criteria, these policy options are feasible, definitely, and they are being implemented by countries. Can easily be included in a robust delivery roadmap and provide space for adjustment in response to changing epidemiologic circumstances. So let me just swap this one. So I feel that I'm talking too much maybe. So let's go straight forward to the conclusion. Although it may be, but just to give you a glimpse, this is what countries are doing actually also is ensure local and national guidelines, incorporate the AWARE categories, monitor and report antibiotics. I just briefly described that, but this is particularly steps that are being undertaken by Benin and Tanzania that are the most progressing country in terms of antibiotic monitoring of antibiotic consumption in the region. So as a conclusion, although it may be unrealistic and undesirable to achieve universal health coverage to all antibiotics at all health facilities, it should be possible to ensure consistent access to key antibiotics. We are calling for the adoption and implementation of antibiotics monitoring program and for more cross-border collaboration between member states. We should scale up innovation mechanisms and emphasize more and leverage on technical resource and capacities of the region, considering that antimicrobial consumption is a full program of surveillance. Thank you so much.
Thank you very much, Aissatou. This is Laetitia from Afro speaking. Thank you, and I apologize for joining later. I have some connectivity issues. I thank my colleagues Arnaud and Aissatou for the brilliant presentations they made. Without so much delay, we are going now to invite Verica to talk on WHO methodology on surveillance of antimicrobial consumption at national level. Verica, you are welcome. Thank you.
Thank you very much. Please just briefly inform me that you can see the screen so that I can go ahead with the presentation.
Yes, we can see you.
Perfect, thank you. So I would like to greet all the participants at today's webinar on the surveillance of antimicrobial consumption at national level. And as mentioned in the chat, please write your name, affiliation, and email address so that we can take record of your participation today. And I'm very honored to present the methodology on the WHO monitoring antimicrobial consumption at country level. We've been working with AFRO since 2016, and this methodology will not be new for some of you. We've been able to also update the methodology so that it now fits into the GLASS ID platform. And I'm going to start by maybe repeating some of the things that Arno mentioned before. Today we are talking about consumption of antimicrobial agents, and the idea is that it is a methodology that WHO has developed and offers to countries as a common methodology to measure consumption at national level. The consumption data mostly refers to estimates of aggregated data, and the data mostly comes from import sales and reimbursement records. As mentioned previously, with the antimicrobial consumption data, we are able to get information on the types and quantities of consumed antimicrobials, not on when and how these antimicrobials are used, because the methodology does not provide information on the patient diagnosis and demographics. It is thereby a proxy for the actual antimicrobial use, and has been widely used to provide the initial signals on how antimicrobials are being consumed and used at countries. Based on our first 2016 version of the WHO protocol on AMC surveillance at national level, we've done the update in this year, 2020. And this protocol is now publicly available for people to download and have a look. And we encourage you to go to the link after this presentation and read it. This protocol has been developed by us at headquarters, and also commented by colleagues at the regional offices, so that we also reflect on the regional and country context. I'm going to present the main principles for the WHO AMC surveillance at national level. The first would be the principle that we are talking about national surveillance programs as part of the National Action Plan for AMR. And for that, our methodology uses standard metrics and classification. The methodology includes all antimicrobial classes and ideally covers all health sectors and thereby has national coverage on the AMC data. Countries are to select the most appropriate source of data for their context, collect the data, validate and report it at national and at global level. And for that, we have created the WHO Glass IT platform to help with the supranational surveillance and report data at global level. So, as mentioned, the first principle is that our methodology helps country build up and sustain their national AMC surveillance program, which means that it is about building up sustainable routine surveillance of antimicrobial consumption. So we are not talking about surveys, we are talking about routine surveillance that is to be done under a national program and under the responsibility of the Ministry of Health of the country. The most appropriate way is to have a national center to carry out the surveillance program. The center can be established and repurposed to manage the AMC surveillance. The tasks of the national AMC program would be to set up the structures and the governance of the surveillance, to define the objectives and develop the national AMC methodology based on the WHO model AMC methodology, then identify the most appropriate data sources for the country context, and as needed, train the data providers on how to collect and report the data. The next step would be for the center to undertake the data collection, validation, data analysis, and then reporting, and finally submit data to WHO for global reporting. The idea is that the national AMC surveillance systems, once established, ensure sustainability and develop long-term plans. The second principle is to have a standardized methodology because that means having standard metrics and indicators to be able to follow over the years and do comparisons as appropriate. So the standardization is about developing a common classification systems and metrics, and the comparisons becomes possible between health facilities, countries, and different WHO regions. We base our methodology on the WHO CC Center, collaborating center in Oslo for drug statistics methodology, and it is the ATC-DDD methodology that we use. ATC stands for Anatomic, Therapeutic, and Chemical Classification System for Medicines, and as you know, it is about active substances that are divided into 5 groups according to the organ or system on which they act, and according to their therapeutic, pharmacological, and chemical properties. This commonly used method for data aggregation then allows flexibility in reporting by medicines or groups of medicines. The unit of measurement is the second pillar of the ATC-DDD methodology, and DDD stands for the defined daily dose. That is the assumed average maintenance dose per day for medicine used for its main indication in adults. And as you're probably aware, it's a technical unit of dose, and it may not necessarily always reflect the recommended or average prescribed dose. So we use technical units, ATC and DDD, for our standardized methodology on AMC surveillance. The third principle is what are the antimicrobials included in the monitoring, and the answer to that is that it is about all systemic antimicrobial medicines available at national level. There are mandatory and optional groups of antimicrobials. The mandatory ones are antibacterials for systemic use. The optional groups include antimycotics, TB drugs, malarials, antivirals, and We have seen over the years that many countries are eager to report both the mandatory and the optional groups of antimicrobials for their AMC surveillance. The methodology does not require reporting the consumption of antimicrobials for topical or local use, although again, some countries opt to do that due to importance in their treatment practices. The idea is that when the consumption is reported to WHO, countries report their total consumption, which covers all health sectors and health levels, and the consumption is reported at the aggregated annual level. Of course, there is an option to, in addition to the total consumption, report consumption by healthcare level or healthcare sector. When it comes to countries doing the reports for their national audience and policy and practitioners, it is optional to either use the global reporting, which means the methods to present the aggregated data at healthcare level and sector, or to disaggregate. And usually countries start with aggregated data and then they move to disaggregated level reporting. Disaggregation usually happens either at the geographical administrative level, rural or urban areas, or at in terms of times. Countries sometimes, for their own reporting dynamics, prefer to do short time period reporting, such as quarterly reporting. The fifth principle is about selection of appropriate data sources. Our WHO methodology is flexible when it comes to what data sources countries should select for their AMC reporting. As we know, countries have different possibilities, and it basically can start from the procurement and supply level. But countries can also go along the medicines value chain up to using records for the prescribing or dispensing of the medicines, or eventually the patient level data for use of antimicrobials. One important comment for AFRO is that the WHO methodology does not include antimicrobials from the informal market. It's only about antimicrobials that circulate in the formal market. For the informal market, we recommend that countries do other types of monitoring, and it is mostly surveys that are to be done to complement the data coming from the formal AMC data sources. It's important in some countries because there are reports that sometimes third or even half of the certain medicines may come from the informal market. When countries choose to use the lowest level of data sources, which is the importer or the local manufacturing data, that means that they include ideally all national aggregated data. They cover the whole population. These data sources have low level of details, apparently because of the aggregation level, but it's also quite easy to collect these data, because this administrative data usually exist in a country for administrative reasons. Some countries choose to move and do their data collection at the wholesaler or distribution level. And we've seen that in many cases in Africa, where countries have central supply and procurement systems. Certain countries start or move on to the third level for AMC collection, and that's at the health facility level. And they use dispensing or prescribing records, or they use reimbursement patient data. For these two levels, the outcome is that they are able to get AMC data with high levels of details, although the collection of data becomes quite complex. Then, as mentioned, the methodology recommends to collect the consumption records for all registered antimicrobial products in the country. And this is very often the first question we get when we describe the methodology to countries. Of course, the easiest way would be to go with a subset of antimicrobials, but we discourage this approach because then the country is not able to get a whole picture of the total consumption of antimicrobials in their countries, and also the relative consumption is skewed. So once we have the agreement that the country should make the effort to collect data of all registered antimicrobial products, these are the details that the country should collect when it comes to the products. So the data is collected at the product level, which means by trade name, if possible. And some countries have a register already of those antimicrobials that are registered with a marketing authorization and are available at their national market. If not, we encourage countries to develop the register. It can be a significant amount of work the first year, but then the register is there to stay and be used for all the consequent years for the reporting of AMC. The product information means that the country should know the ATC or the substance, the content, and the route of administration of the medicines. Then the other important information is the number of packages that are consumed for each of the products. Based on these two information, the product information and the number of consumed packages, the consumption computation can be done. And then the sum of the consumption is done at the ATC level. Our Excel template that we are going to present a bit later helps country to automatically compute the consumption, but the countries should still provide the product information and the number of packages to be able to do this macro computation. These are some of the computation examples for you. I won't go through them, but it's good that they are kept here for your information once you go through the presentation later on. Once the country gets the information on the substances and the number of packages used in that country for that year, the next step would be to also estimate the population that consume these medicines, because that is the denominator data in the final consumption, in the final computation of the indicators. The population size needs to be adjusted to the volume of the antimicrobials that are consumed. Ideally, when we talk about national AMC estimates, we want to have the total national population as a denominator. But certainly the population size depends on the type of data. So if we have reimbursement data, we are talking about a subset of AMC data because it relates only to the insured population, while the import data normally should cover the total population of the country. And then it also depends what coverage we have of the data. If the country is able to collect all data on AMC, then we talk about the total population of the country. But if the country knows that only a certain percentage of the data has been collected, then the country should be able to also estimate the percentage of the population size that is covered with this consumption data. Then the way to report it is also to be standardized so that we all speak the same language and are able to do the comparisons in a standard way. The metrics to report the volume of consumption are the DID, or the number of defined daily doses per 1,000 inhabitants per day. And the interpretation of the DID is that it represents the number of individuals out of 1,000 individuals that are on antibiotic treatment in one day. If we are able to also produce data on AMC in the animal sector, then countries are encouraged to also report the volume of consumption by weight. Then the key indicators are to report both the total and the relative consumption, the total consumption being the quantity of all antimicrobials reported as DID or as weight. And then for the relative consumption, the reporting can be done according to the country needs, mostly by pharmacological subgroups, the route of administration, the aware categories, etc. So a summary would be that there are three elements that WHO AMC methodology requires. First is the collection of the antimicrobial consumption data, then the denominator data that relates to the population under monitoring. And then we also encourage country to provide data on the context so that we know, and they also know, to what health sectors and health levels these data refers to. The last principle is the reporting at a supranational level. And for that, we have developed the WHO GLASS IT platform. And countries have quite a lot of benefits by becoming part of the GLASS AMC system. First, they get trained in the standard methodologies on how to collect, analyze, and report data. Then they are able to also do comparisons with other countries in the region and globally. They become part of global networks and are able to also use the GLASS infrastructure, including our IT platform functionalities on analysis and reporting. And at the end, countries get help with validation and reporting by WHO experts and GLASS AMC team in Geneva. Data is finally on national level included in global reports once the country approves that. Arne is going to talk about the participation in GLASS AMC. I'm just going to say that it's quite a formal enrollment that is done by national governments agreeing to participate in GLASS AMC. For that, they have to sign an agreement, nominate a national focal point for GLASS AMC and register in our platform, and then start submitting AMC data annually to GLASS AMC IT platform. We talk about this as a long-term project. WHO started with a pilot program on collection of AMC data, and we were able to publish a report in 2018 with 2015 and 2016 data coming from all regions. Here I have two graphs to show some of the AFRO data. 4 countries were part of the pilot data collection and were emphasized in our report. we've been able to work with them and estimate the total consumption by country, and also go further with the presentation of the relative consumption by pharmacological subgroups and also by the aware categorization. We support countries with tools because that helps increase the expertise of the countries, especially when it comes to how they collect the data, product and population size collection of data, and also how to use the ATC-DDD system. For that, we have an Excel template, which is a standardized way of how countries collect and report data to us. And we plan to release in the future more IT tools to help countries collect and analyze data. This is the AMC template. As you can see, it's quite simple in its structure, but it has the macros to compute, help countries compute the consumption based on their product level data and population size data. And then the macro also helps countries format the Excel template for submission into GLASS. And then based on countries' request, we also developed our first manual on data management. This is available online, and the idea is to help countries collect the data, enter the data into the template, and then carry out basic analysis. We help countries and experts that work on that learn about the WHO methodology, and also plan to update this document as countries report further needs for WHO support on data management. We are very close to also release online training modules for countries that will help them learn about WHO methodology and the process of data collection, analysis, and reporting in online training, and it is to be released by the end of this year, and we'll have 5 modules that go into very many details and practical examples of how to do the work. Then the last slide would be that we have also been given the opportunity to produce a big AMR surveillance course as part of the WHO Academy. This course is titled Antimicrobial Resistance and Antimicrobial Use Surveillance, Competencies for Policy and Practice. And we have a whole module on AMC surveillance at national and at local level. Once we start developing the course in a couple of months' time, the formal deadline to release the course and make it available to everyone globally is the end of 2021. And because it is part of the WHO Academy, it will be translated into all 6 UN languages. With this, I thank you for your attention, and I leave the floor to the next presentation, or if we decide Q&A session over.
Thank you very much, Verica, for this brilliant presentation on WHO methodology. I'm sure if there are questions, they come. And we continue with Arnaud. Do you have your presentation ready?
Yeah. Yes, Laetitia, I'm sharing my screen. Do you see the screen?
Yes.
Yes.
I have a short presentation about the data submission of national antimicrobial consumption data. This is a new process, as was mentioned at the beginning. The antimicrobial consumption has been integrated into the GLASS system, and now there will be, like it is for AMR surveillance, there will be regular data call, and we expect countries to submit national consumption data to the WHO. The aims of GLASS is first to support our member states in establishing national surveillance programs on antimicrobial use and resistance, that they can obtain reliable data at national level, and then can provide this data to GLASS. And of course, at global level, the aim is to collate all this data that you are reporting to us, analyze them, and then provide a global report on the level of use of antimicrobials worldwide. And our countries will report national consumption data to GLASS. It's a two-step process. It's a formal process because we request countries to formally enroll in GLASS AMC, in addition to GLASS AMR, and that's important that even if you already enroll in GLASS AMR, it's important to enroll also in GLASS AMC. Why? Because we have different focal points in the countries for AMR and for AMC, because we need different expertise in countries when we have to deal with issues with AMR data or with AMC data. And when countries are enrolled in GLASS, then they will have access to the GLASS platform, and then they will be able to submit the data through the GLASS platform during annual data call. The enrollment process, that is the same process for the AMR surveillance. First, you need to notify us of your willingness to enroll in GLASS AMC, and also regional offices already communicated, started last year in December before COVID-19, but we will share again with you the information about the GLASS AMC enrollment if needed. Basically, what we ask you to do is to nominate a national coordination center for AMC in the country, the national body responsible for AMC in the country, and also to nominate a national focal point for GLASS AMC, which this person will be responsible for the communication and data exchange with WHO as part of GLASS. And that will be done through a letter signed by the Ministry of Health and sent back to WHO through the formal procedure in countries. And this enrollment process is coordinated by WHO headquarters in Geneva, but also each of the regional offices. For the data submission, as I mentioned, every year we will open a data call to let countries submit the data from the previous year. But if it's the first time you collect data, it's important if you can provide 2 to 3 years of data, because then it will be stronger data in terms of interpretations if we have 3 years compared to 1 year. But the normal rule will be to provide the data from the previous year. We expect the data call to stay open at least for 3 months. We need to fix the duration of this data call, because we know it takes time for countries to collect the data, process the data, validate the data before they're able to submit the data to the WHO. And we also encourage the countries to start collecting data before the beginning of the data call. At least you already communicated with the data providers, received already some data. to ensure that you will be able to report by the end of the data call. But by experience, we also let the countries to resubmit retrospective data in case you find errors in your data. And by my experience, it's happening often that 2-3 years after you will identify mistakes and you want to resubmit data for this whole year. Or if you were not able to submit the data by the end of the data call, you will still be able to submit the data to the WHO. The only thing is that we may not ensure that your data will be in the next annual report, depending on the timeline, if we have time to include or not the data for the publication of the report. But it would be based on online databases at later stage. As I said, the data collection process, what you have to do every year is first to collect, then validate your data, analyze and report. And at the end, assess all the process and maybe needs to improve your data collection system. And as you can see that the collection, the validation of data will need to have interactions with the data providers. And you can see that the interactions with WHO can start at later stage. When you start validating the data, you can start to communicate with us. By experience, we know many countries come back to us when they start validating the data. They're not, it's new for them, then they're not so confident, and they want to have some confirmation from the WHO about the data before they start publishing the data. When we look specifically at the data submission process, of course, you have to collect the data first. And when your data are ready to be submitted, as I said, the data will be submitted through the GLASS IT platform. The GLASS IT platform accepts one standard format, which means that countries have to use this format to submit the data. As Felix mentioned, for instance, with the Excel file we are providing to country, there is a macro that will generate this file automatically from your data. When you have the data in the right format, then you upload the data into the platform. From the platform, you will have options to validate your data and to approve the data. And when that's done, then we will look at your data, check out your data, and at some point we'll flag this data as published when we publish the GLASS report. In addition to the data and consumption, we also asked you to report additional data. Like for the AMR surveillance, we will have some basic questionnaire about the level of implementation. And at the beginning, it will be probably through emails, but we might move that also into the GLASS IT platform. What we have in the GLASS IT platform, we also have a questionnaire about the data, about the context of the data. For example, which class of antimicrobials you have reported, which sectors are covered by your data, which data source you have used, and what is the coverage of the submitted data. This is important for us to interpret your data, to flag your data, for example, that there is a low coverage, and even to discuss with you if we have to publish or not the data, if for example, the coverage, or there is some important bias, if we should publish or not your data. This is graphically, so these steps, you see that the first step is from your side on the top, upload the data, the GLASS platform do some automatic checks, but not all checks. Then you will have to validate the data. And at some point, you will approve your data. And we, as WHO, will be notified by the system that you have approved your data. Then it's now up to us to work on the data. We will validate from our side. And the validation will be mostly to see if there is outliers, if if your data makes sense, and if not, we will come back to you. We will validate the data at one stage, and when the data have been validated by WHO, that's where we will start working on the data for reports. Then until you and we validate the data, we won't do any reporting with this data. And when we publish the GLASS report, we will flag this data as published. And you see that when you approve the data, we are notified. When we approve the data, you are notified. When we publish the data, you are notified through the GLASS IT platform. Important point, the last point I want to mention for that is that until you approve the data, this is your business. You can upload, check, if there's mistakes, we upload. We don't care at WHO. As soon as you approve the data are blocked from your site because now we are working on it. But if you identify an issue at this stage, you can ask for revocation of the data. Then there is a function in the website. You click on the button, you justify why you want to revoke this data, and we stop to work on this data. And you're allowed again to re-upload the new data. It's to avoid that we work on data that are wrong, or you change the data when we start developing report, and then there is an issue with the data because we have not worked on the same data that the last data you submitted. That's it for the GLASS data submission.
Thank you very much, Arnaud. We now open the question and answers session. So far, we heard about 5 presentations. There was the process for online consultation. Then Arnaud presented on why to monitor antimicrobial consumption data. We heard about Aissatou, who was presenting on the progress so far made in Africa on management of antimicrobials. And then Verica presented on WHO methodology for AMC data surveillance at national level. And we just heard from Arnaud about GLASS data call. We have already 3 questions in the chat. A question from Diana from Liberia, a question from Moses, same for Liberia, another question from Blesmo Chaiva, and Arnaud and Verica. If can start with the first question. Diana is asking, how can a country apply for training on the use of standard methodology for drug utilization research? Over to you. Thank you.
Yeah, thanks for the question. As I said, we will have one training on monitoring consumption, an online course. The thing is, this drug utilization research is cross-cutting. It's also part of the medicines department in WHO. I don't have a clear answer about the WHO training. Verisa, maybe you can mention the different epidemiological groups, international groups. Maybe that could help on this.
Yes, thank you, Arnaud, and thank you, Diane, for the question. So there are a lot of regional groups that are basically research groups on drug utilization research, and I'm going to put down the website for that Global Society on Drug Utilization. It's called ISPE. What we as WHO headquarters team offer is training on the WHO methodology on the monitoring of antimicrobial use, consumption in this case. And if we are talking about these trainings, then the national request usually goes to the regional office and then it comes to us. We used to do physical webinars, 3 days webinars with country representatives in the past. And as mentioned previously, we are now also finalizing our online training on how to collect, analyze and report data on antimicrobial consumption at national and at hospital level. Over.
Thank you. Thank you, Verica and Arnaud. I hope Diana is satisfied. There is a comment from Moses who appreciated the presentation. Thank you, Moses. Thank you all who appreciate it. And he's saying that they will appreciate the various flexible, adaptable reporting tools, e.g. spreadsheet for AMC. Arnaud, Verica, do you have a comment on that?
Yeah, at the moment we share the documents when we start working with countries, but we plan to put it on the WHO website that is available with documents. And I will check because all this presentation will be on the GLASS 2020 website. And I will see if we can also add the Excel on the GLASS 2020 with the recording of the webinar and the presentations. Otherwise, if you have a specific point on that, you can contact, email the GLASS AMC at WHO website. I'll put the link here. Then we will share the document.
Thank you, Arnaud. There is a question from Blessmore. In a country project, AGISA, we try to calculate the DDDs, but these were not making any sense. Is there a way of interpreting data in this methodology does not give results as intended? Over to you, Arnaud or Verica.
I can start, maybe Verica, you can add, but I mean, it's not very clear the questions, what the issue was. When you start looking at the consumption in DDDs, there is basically two ways to look at the data. Is to look at the big classes. For example, if you're looking at data in the community, you would expect that majority of the consumption will be with penicillins. I mean, penicillins or amoxicillin or amoxiclav. Then if your profile with you see that you have a huge consumption of fluoroquinolones, the majority of the consumption is fluoroquinolones, for example, then you can start to think, is it correct? It's not what we expect. And the second way to look at the data is to report the consumption on the population under surveillance. And I know the AGISA is not a national project, and it's difficult to estimate the population covered by the data. Then maybe this would be difficult in the case of the AGISA project, but definitely looking at the relative proportion of each of the antimicrobial antibiotic classes is the first way to check the data. I don't know, Verica, if you have any other points.
Just a quick add to that, also looking at the data over time might be a useful way to start looking at data. Once you have at least 3 years of data to see what changes, what are the changes that happen over time.
Yeah, and I think it's also what we do at HQ when we receive your data. What I said, when we do the validation is what we look. We look at the proportion of the classes, the level of consumption, and we compare with other countries and over time. And based on that, we consider data okay or not. Over to you, Laetitia.
Thank you very much, Verica and Arnaud. I hope Blissmore is satisfied. Otherwise, he will again come back to you with more precisions. Diana also asked, can a country that has not submitted any data on AMR submit AMC data? Secondary, is the AMC focal point different from the AMR focal point of the same country?
Yes, you can. There is no problem. You don't have to submit AMR data to submit AMC data. In fact, we have already, I think we have 2 countries that are enrolled in GLASS AMC without being enrolled in GLASS AMR. And I think the 2 countries are from Africa. I know, for example, Niger and South Sudan are enrolled in AMC only. And Niger already shared some data. Then you see they moved without having been in the GLASS AMR. As I said, for the focal point, it's better if we have someone with experience on antimicrobial consumption, but we have the example of one country in Africa where, in fact, the same person has been nominated for AMR and AMC, but then the alternate, because we ask also for the alternate focal point, then the other alternate, for instance, in this country is from the regulatory authority.
Thank you very much, Arnaud. Blissmore asked again, is there a time frame, like a season or a month, in which the call for data submission is made, and is this standard across the year?
Yes. We expect, starting from next year, to have the data call open in spring and finish, which means probably March. We still have to, March or April, we have to check exactly, and closing end of September. This year is special because of COVID-19, everything has been pushed back. We have opened the data call, and I think this year the main objective of the data call is to get more countries enrolled in GLASS AMC than to provide the data to the WHO.
Okay,
if I can, Laetitia, if I can just add, just to clarify that the reverse is also correct. If countries are enrolled in GLASS AMR, it does not automatically mean that they can submit AMC data. So although we belong to the same GLASS family, the registration or the enrollment process are separate processes, and it is a different individual, let's say, process to AMC and AMR. Although the ideal situation would be to have both AMR and AMC data submitted and then start using the data in a systematic way over.
Good morning. Can I also step in on the issue of different focal points on AMR and AMC? So good morning, colleagues. My name is Carmen Pessoa. I am a colleague of both Dr. Veritza and Dr. Arno Miller. And my point here is that, yes, as both Arno and Veritza highlighted, we have different areas of expertise for antimicrobial consumption and the resistance of pathogens to antimicrobials. And this may be then the countries that have enrolled for both AMR and AMC, they may have even 2 different focal points. But what I'd like to highlight is that it's so important that doesn't matter the number of focal points that the country may have for the several GLASS components. It's important that all focal points exchange the information and discuss among themselves what does it mean, how to bring together this type of surveillance data for policymaking. So no problem, the country can have as many focal points as needed, but what is really important is that they communicate among themselves. It's just these cents. And thank you so much for the brilliant presentations. Bye-bye.
Thank you, Carmen. Thank you very much for intervening on this. And Bakari just requested the slides. They will be shared. And there is Zivanai who would like WHO to share a worked examples to guide countries when calculating AMC data. I think Arnaud can comment on that. Thank you.
Yeah, for the slides, they will be shared on the GLASS 2020 website. Then if you're not yet registered on this GLASS 2020 website, I mentioned in the beginning, the first presentations, please register in that, and then you will have access to the slides and the recording of this webinar. For the last questions about the examples and guides for calculating AMC data, this is exactly the purpose of the manual for data management that Lexa mentioned, where we guide users to use the Excel template, how to fill the Excel template, and how to do basic calculations and reporting of antimicrobials by class, for example. And of course, when we do training with countries, a big part of the training with the countries is about this point. Over to you, Laetitia.
Thank you very much all for your questions and for the panel for their answers. We now move to the last presentation. The last presentation is about hospital surveillance guide. And actually, this is the document that will be requested to comment on. And Verica is going to present that. Thank you, Verica. Over to you.
Thank you again. So I'll walk you quickly through our second document that is a subject of the WHO GLASS consultation on the AMC subject. And countries and participants will be invited to make comments on this specific document. We know it's true that most of the consumption and use of antimicrobials happens at the community level, but monitoring AMC at hospitals is also important because the density of antimicrobial use is much higher in hospitals, and they're highly vulnerable patients that are harbored in narrow spaces. So for that, AMC monitoring in hospitals is very important for the stewardship effort in hospitals. We mentioned earlier that both antimicrobial consumption and use can be monitored at hospitals. Those are two very different approaches. And for the sake of this presentation, we are going to talk about, again, consumption data, this time at the facility level, which is different from the patient level data and the PPS, the point prevalence surveys that we also do with WHO methodology. Again, we are talking about estimates of consumption, this time at the hospital level. And the data can come either from hospital procurement data and cover all patients in the hospital, or it can be disaggregated by wards, and then we can have a look at the consumption by specialty. Again, consumption is monitoring is good for routine surveillance at hospitals, and they provide important data for comparisons between different hospitals that are at the same level and have same specialties, and also over time. It should also be mentioned that it is critical to know the percentage of medicines, at least roughly, the estimates of percentage of medicines that are obtained out of hospital, because that is important for the interpretation of the AMC data in hospitals. In our now established WHO methodology for AMC surveillance in hospitals, we talk about pharmacy-based surveillance, and it means that we focus on data collection from a hospital pharmacy. This is the entity that is responsible for the central supply of medicines in hospitals. Our WHO methodology does not include medicines that come from outside the hospitals due to stock outs and problems in supply. So therefore, it is an important to at least estimate the percentage of drugs that are usually purchased outside of hospitals when the data on AMC in hospitals is interpreted. We mentioned that AMC provides information on the types and quantities of antimicrobials, not on the patient diagnosis and demographics. Therefore, again, AMC in hospitals is a proxy for actual antimicrobial use in hospitals. We have just released our first glass guide for national surveillance systems for monitoring AMC in hospitals. Here you have the link to the publication, and please have a look at it. As I mentioned, this is the subject of the glass consultation on the AMC consumption, on the AMC monitoring with member states. The guide is supposed to guide help countries establish their national surveillance systems for hospital monitoring. The next document we plan to do in this work stream is a WHO glass protocol on surveillance of AMC in hospitals. That would be a more directive and instructive document on how to collect data in hospitals. For the time being, this is our document, and we'll talk about this in this presentation. So we use the same methodology and the same principles to survey AMC at hospitals, and it is only adapted to the hospital context. The importance is that the structure and the functions of the AMC surveillance at hospitals will depend on the national surveillance scope for AMC, what is the data availability, and how hospitals participate in the national AMC surveillance system. Therefore, the national facility AMC surveillance is to determine all 4 elements for the national surveillance in hospitals, and it is about organizational level, hospital sector, time intervals for data collection and analysis, and antimicrobials groups that are part of the monitoring. We go through each of them now. So the first important thing for the national program would be to determine the organizational level for the monitoring. Obviously, the most aggregated and high level is to monitor AMC at the hospital level, where the level of details is the lowest, and the complexity for data monitoring is also the lowest, but the coverage is the highest. Countries that have the opportunities can also move from an aggregated hospital level to a medical, to a department, or to the unit, specialty, even patient level. And that will change the process of data collection as well as the national surveillance system at hospital level. The second thing is to define the patients that are to be included in the monitoring. The WHO methodology is about including inpatients, from all relevant departments, and mostly that concerns patients coming from acute care departments. Some countries expand to long-term care, day clinics, etc. But the minimum would be to look at inpatients that are hospitalized in acute care departments. Then again, there are different choices of the frequency and time intervals for data collection and analysis. The minimum would be to collect data annually, although we understand that some countries and individual hospitals move to a more frequent data collection, which is usually quarterly or monthly, and it is because that helps also interpret the AMR data they collect at their facility level, and also use that for stewardship purposes. Again, it is about collecting data of all systemic antimicrobial medicines. The groups that are mandatory and optional are the same for both national and hospital surveillance. And our WHO methodology is not about collecting antimicrobials for topical and local use for the monitoring of AMC. There are differences, different options for the AMC data sources at hospital level. As you can see, the most aggregated, the highest level is to use the hospital pharmacy purchase data, going down all the way to prescription data at patient level. And it all comes with different level of details, complexity for data monitoring, and purposes for use. Denominators are the main thing that is different between the national and the hospital methodology for AMC monitoring. As you remember, for national, we talked about 1,000 inhabitants per day. Here we talk about denominators that are related to the hospital activity indicators. The 3 recommended standard indicators to measure hospital activity are patient days, occupied bed days, and admission discharge. The metrics for reporting at hospital level is again similar to the national level. We use ATC and DDD system. Although now the adjustment is to be done by hospital activity indicators. The metrics are therefore number of DDDs or number of DDD per 100 patient days or number of DDD per 100 admissions. There are different type of analysis that can be done at hospital level. Again, it can start with the total consumption of antimicrobials and then move to the relative consumption by pharmacological subgroups, aware categorization, route of administration, etc. Hospitals and countries can also look at the AMC trends over time and then start doing comparisons between different hospital units or between hospitals for benchmark. This is my last slide, and it is to provide an example, a visual example of the work being done in the UK on the antimicrobial consumption monitoring in hospitals. You can see a table which contains data from 6 years, and it's being disaggregated by different specialty within hospitals. When it comes to WHO, our methodology for monitoring of AMC in hospitals has been piloted. Our 3 pilot countries were Jordan, Peru, and Laos, and these countries were able to collect data and share the data with us. the main recommendation is that they now work towards establishing their national system for hospital AMC monitoring, and as mentioned before, share this data with the audience that can then use this data in collaboration with the labs, AMR, data analysts, and policy makers. I stop here. Thank you for your attention, and I hand over to Arno to give you some details on the consultation process for this document. Over.
Okay, yes. Before we have the Q&A session for this document, as it was mentioned, we will expect member states to provide comments, their feedback on the guide for establishing the surveillance of consumption at hospital level. And for that, all this consultation, as I mentioned at the beginning, will be through the GLASS 2020 website, which is mentioned here on this slide. But you need to be registered, and you have to register on the website to access the document. If you need more information, it's better that you contact Laetitia at AFRO office, and she will guide you into this process for registering into the GLASS 2020 website. Now, in terms of feedback, as I mentioned also, we will open the window for feedback between 15th of November to 15th of January. And for that, when you have access to the GLASS 2020 website, you will have to go to the thematic area on AMC AMU surveillance methods. And when you will on this thematic area, you will have options to download the documents. At the moment, it's on English, but we are preparing a French-Portuguese version, and normally it should be ready by the end of the month. Then you will be able to download French and Portuguese version in addition to the English version. As part of the thematic area, as mentioned, there will be also a forum as a chat where if you have any questions related to the guide, but also more in general about the AMC AMU WHO methods, then feel free to ask the questions through this forum or chat functions, and we will reply in coordination between regional office and HQ to the users. And then, of course, there will be also an online form for assessing the document. But in this case, we ask you to not report by individual, but to provide one feedback per country, which means that you will have to discuss between you at the country level about the feedback, and then decide one person will report the feedback through the website for the whole country. That's it for the procedure for the feedback on this document. Over to you, Laetitia.
Thank you very much, Arno and Verica, my colleagues from AFRO, and the Carmen, the entire team from HQ for organizing the logistics. And of course, to all of you, dear participants, without you, this webinar would not happen. So we are at the end of the webinar. If there is any question, please feel free to write it in the Q&A window. So otherwise, welcome to the online consultations. And this afternoon, we'll have the French session. Thank you very much. And this is the end. Bye-bye.
Thank you, everyone. Bye-bye.
Thank you, everyone, and bye-bye.
Hi, Arno.
Bye.
Hello, Arno.
Yeah.
Please, you have to keep.
Sorry. Mamoto, yes.
You have to keep the line on.
Yeah, no, I'm just trying to save the chat.
Okay.
But I don't find ways to save the Q&A. But I think the most important is we get the chat. Okay, I will leave now.
Don't. That's what I'm saying. When you are going, don't log out. You leave the link open.
Okay. Wait a minute.
So you come back. Okay.
Yes.